Hello again. This is Kathy Grace. I'm the co-director of the Graduate Center for the Study of Early Learning, and I'm so happy that Dr. Susan Buttross is joining us today for our conversation. Dr. Buttross is the professor of pediatrics. She's a developmental behavioral pediatric specialist, and she is the director of the Child Development Project and a friend of mine for a long time. So thank you, Dr. Buttross, for joining us today. And we just want to let you tell us a little bit about the work you're involved in now, because you and I have been doing this for a while. And I think this is something that's a new project, sort of new. So just talk to us a little bit about what you're doing.
Yeah, Kathy, thank you so much for having me. It's a pleasure. And yes, we've been working in the arena of early childhood development together for over 30 years right now.
I think
And
so.
but I have for 30 years, I really worked predominantly in seeing children in the clinic, seeing one patient at a time. And actually, almost 5 years ago, I decided it was time to really try to work on a systems build and make some changes for our state, because we knew that things needed to change. We continue to have, and I know everybody knows this, but we continue to be on the bottom of all the child health and wellness parameters across the nation. And we really need to move off that bottom needle. We occasionally make some changes, but then it moves back downward. So I would like to tell you a little bit about my project. It is a HRSA funded project. It's the Health Resources and Services Administration, a federal granting agency that has granted our university, the University of Mississippi Medical Center, with a collaborative agreement between us and Mississippi State University, the Social Science Research Center, to work solely on early child health and development. And it's called the Mississippi Child Health and Development Project. We actually, our program officer at HRSA nicknamed it Mississippi Thrive. And we have that with an exclamation point, because that's we feel strongly about this project can help Mississippi thrive. It was originally a 3-year project back in 2017, and we are getting ready to go into our 5th year. The whole purpose, like I said, is to improve child health and development, but it has 3 major prongs. One is to improve the developmental screening and linkage to services and implementation of the interventional services that young children need from birth to 5. Within that is literacy, improving what parents and caregivers know in the childcare sector, in the education sector, in the medical sector, what they know about early child development and how incredibly important the first 3 years of life are as far as brain development and learning. And if we don't focus on those years, the difference it can make in ultimate outcome. The other piece that we're working on is workforce expansion. And that is in the medical community, but also in the childcare community, to expand the knowledge, to increase the number of individuals who really deeply know about early child development, early learning, early brain development, developmental screening, what to do after you discover a problem is there. In the childcare arena, how to help children in early brain development, how you encourage singing, reading, talking to children, and how important it is that they do that. And then, so workforce, we've had a fellowship program that has had intensive training for allied health professionals like speech therapy, occupational therapy, nurse practitioners, psychologists, social workers, and physicians where they take a year post-training of intensive dive into early child development. So all that's so important. But then to me, now the most important piece is working toward what we call little p policy changes, the small policies that are implemented in anything from early intervention to the schools, to childcare centers, how things are done, to the big P policy changes, putting more money into those areas that can make a difference later for children. And that policy work is a big piece of what we are going to be doing in our 5th year to help make recommendations for the overall systems change that our state needs to help our families, to help our providers out there who are taking care of kids be in a system that works, that has appropriate contributions to it, and thus can ultimately have good outcomes. So it's been a big project. It's actually in the Sprans office, and that's of HRSA. That's the Special Projects of National Significance. We have one of those. It is the largest grant they've ever, as far as I know, funded for a project such as this. And our plan is to have systems that other low resource states with high needs, like Mississippi, are able to go by. I know that was a lot about our project, but it's something, one of the biggest pieces, Kathy, and you and I have talked about this often, is that we did early on into this work, and we're continuing to do this, is we finding that there is so much incredible work being done in the area of early child development, but it's been siloed. You know, this group does this work, this group does this work. And then when their grant or their funding goes away, that work goes away, and then it gets lost. And so I'm excited that our work has allowed us to start holding hands with other groups, yours being one. You have some of our wonderful team members working with you on a project right now. We've been working with several other entities like Mississippi Families for Kids, Families as Allies, where we've worked with the early childhood inclusion centers. There's so many people out there doing this work, but it's been done maybe in parallel or in those silos where we're duplicating work, and we've got to stop that.
Well, you brought up a lot of interesting points, and I want to pursue a couple of them with you as far as the difference in silos and systems, and that our state, being as rural as it is, we still are missing children and families, even through silos, because we don't look at it as a statewide, in a statewide way or statewide picture. With regard to, let's just say you mentioned developmental screening as one of the interest areas, one of the focus areas. How do you see us as a state being able to move that through some sort of systematic way so that we can determine early on in a child's life, and not when they get to school, that there may be a developmental delay, a speech problem, or something to do with vision or hearing? What would be some of the things that you think we need to consider as we're looking at just that one aspect that obviously is going to have impact on all other aspects, but that one aspect?
Right. That's one area that we've done a lot of work in and have looked at that. So one thing that we found is Mississippi, through the National Children's Health Survey and a Mississippi survey that was done by the Social Science Research Center, that children in Mississippi are not receiving that developmental screening that needs to be done. It's an evidence-based formal screening that can look at young children starting. Typically, the recommendation is to do a formal screener at 9 months, at 18 months, and at 30 months, 24 or 30 months. And then anytime you are concerned about a child, that developmental screener can be done in a child care center. It can be done by any trained individual or in the medical home where child checkups are being done. It can be done on entry to child care, as I mentioned. But what we were finding is that less than 30%, actually, one of the surveys said about 28% of Mississippi children are receiving those formalized developmental screening. If you're just watching and using what you think is your expert knowledge, even trained pediatricians are not accurate at just watching a child and determining whether they're delayed or not. So what's happened is many children, upwards, according to a couple of surveys that have been done in Mississippi, upwards of 45 to 50% of children are entering kindergarten not ready for kindergarten, which means that they start off behind. Now, does that mean that they all have significant severe learning problems? No. Some of them have social emotional issues where they've never been around other children and they don't know how to interact and share with other children appropriately. So the other thing that we found, so a lot of kids aren't screened, but what else we found out is that once they are, a lot of providers get really frustrated because they screen them and then they can't get them into services if they find out they have something that's needed. And why is that? It's because we do not have enough money being contributed to taking care of these young children and their special needs, either because we don't have the workforce there, or in especially rural areas, and we've talked to lots of families about this, they might have to drive 45, 50 miles for services. That's just hard on anybody. But if you are a low-income individual and trying to make ends meet, and then trying to buy gas, and if you're trying to work, then you have to take off from work. So we've got to fix that system, because if you think about it, if a child enters kindergarten happy, healthy, and ready to learn with no developmental delays, or if the delays are there, we know about them and can address them early, then that child has already started on stable footing instead of rocky ground.
Well, you mentioned a couple of things which also feeds back into your workforce training and the other one of your other aspects in trying to grow the capacity of people in the state. With regard to, and this is just to help anybody who's listening, could you just give a quick overview of what early intervention is versus what the public schools responsibilities are, so that people understand age has something to do with who's in charge of providing services and such?
Yeah, sure. The early intervention services are birth to 3 services. Those are based in different states. They're based in different places. But in Mississippi, our early intervention services are based in the Department of Health. At 3, there's supposed to be a smooth transition where children who are in early intervention services and continue to need services then move into the public school system. So from 3 to 5, if we're talking about birth to 5, the services that are supposed to be imparted from 3 to 5 are based in the public school system. So they're two different state departments that are managing those services. So one area that we do have too is that though there's supposed to be a seamless transition, a lot of times that doesn't happen. And children fall out of services and the services don't get picked up until much later. So you have that gap and loss of time for children. I hope that makes sense. So what are those services that can be imparted? It can be speech therapy for a child who has language or speech issues. It can be occupational therapy for a child who has, say, problems with small motor skills, block building, handwriting, and things such as that. Or it can be gross motor services, physical therapy. And then certainly academic issues as they get older. But typically they're separated into those three therapy modes, plus educational services can also be given.
So again, with our folks in a lot of rural communities, if somebody hasn't coached them or advised them on, if your child is 2, this is who you go see. If your child is 4, this is who you go see. So we also have a consumer or a parent education issue as far as informing the general public about how our systems are set up and who you go to see who, when, and so forth.
Right. We've worked hard to try to compile a lot of those. We have a website, MississippiThrive.com, and you have to type out Mississippi all the way, but it's MississippiThrive.com. And in there we have all about those services for childcare providers, for teachers, for medical providers. And we also include links to other great services out there. So, but you're right, Kathy, that one of the big issues is that we need to improve the general health and development literacy of parents and caregivers out there so that they know what they need to be looking for. And so hopefully many of you who are viewing this have seen some of Mississippi Thrive's work, but others' work. There's so much going out there trying to improve that literacy.
Let me ask you a related question, and not to get into the politics at all, but I know when I have read over and over again with regard to COVID-19 and the Delta variant that people are encouraged to go see their doctor, go to their medical home. I also know that in Mississippi, we have, with again, low income people who are not on any kind of Medicaid or other services that they could take advantage of, that they don't have a medical home because they usually go to the emergency room if they have an illness. Is that another issue that feeds into our problems with the children being able to be identified early on? Because if they're just there for a sore throat, or if they're because their ears are hurting, or they cut their arm or whatever in an emergency room setting, that's not the same view that a physician would have as if they were coming in for a well baby check or so forth.
Right.
Am I right about that? Does that make sense?
Yes. Let me point something out. Many children now, whether we talk about Medicaid expansion or not, we know that many children, I would say upwards of probably 95% of children have some sort of medical coverage. A large portion of them qualify for either Medicaid or CHIP. Many individuals, though, are still not enrolled as they should be. So that's one problem. And the other issue is that many who are enrolled don't have a medical home. And you mentioned something that is so very important, that medical home, so that, if you have a provider, whether it's a pediatric nurse practitioner, a family nurse practitioner, a family practice doc out in the rural area, or a pediatrician, having someone who knows your child, who knows when a change has happened, who understands what's going on with the family is incredibly important. That's the only way we can make sure that our children get the best care that they can. I'm going to mention something else while we're talking about Medicaid versus CHIP versus other insurance. Private insurance, actually Medicaid in our state does a pretty good job about covering services for children in need. They'll cover developmental screening. They cover that early periodic screening. In fact, they require it for the medical home to do that. And actually have recently, thanks to some work with what Drew Snyder has done, is they've actually separated out reimbursement. So when docs do, or nurse pracs do developmental screening, they get reimbursed for it. Private insurance doesn't do that. The major private insurance provider here in our state does not do that. So our children who are in that, say, middle class, or, as we sometimes call the working poor, the people who are not making a huge income but do have private insurance, are getting poorer services than children, at least have poorer coverage for the things that we are talking about than children who have private insurance from our major insurance carrier. So that's something that really needs to change. I know I'm skirting into maybe a political topic, but that is something that I feel pretty strongly needs to be addressed as we're moving along. So all children can have the services that they need, whether they have Medicaid or private insurance. And back to the medical home piece, there are some very rural areas in our state where it is harder to access a medical home. And that is something that our rural health program at UMMC is working on. And Dr. Loretta Jackson has been doing a great job on working on that.
Well, I know you're a big proponent of telemedicine. And if you could just give us just a very brief explanation / example of how, if we increased or maybe just added to what we understand about telemedicine, that there would be one way to reach folks that have not been able to have the services we've talked about.
Yeah, sure. Always face-to-face medicine is better than remote, because no matter how good your equipment is, it's still not quite the same. But I think we've all learned over the last couple of years how well it can supplement things. So let me give you an example. So you have a child that comes into our Center for the Advancement of Youth, and they have a physical exam, and we find that these behavioral recommendations need to be made, say for sleep help. The child's not sleeping well, and we do a physical exam, we check the child, everything's okay, measurements are okay, but we send them out with recommendations. Now, typically in the world previous to telehealth, you'd send them home and then you'd have them come back in a month, come back in 2 or 3 months to see how we're doing. With telemedicine, You can check in without having them have to come back into your office. Now, there are two ways telemedicine's done. And one is where you can go directly into the home on the parent's laptop, on their iPhone, and check in with them, give advice. And I do this often. In the world of developmental behavioral health, a lot of what I do is giving advice and checking in with how things are going. So if this mode of behavioral intervention or sleep recommendations didn't work, then here's some more advice. Now you can talk to the child, you can see how they look, you can talk to the parent and answer the questions without having them travel that, our office is 3 hours from some parents. So you can do it. Now, even in the medical home, here's another example. During COVID, many of our private pediatricians, private practice pediatricians or pediatricians who were in other areas of service, when COVID was so bad, it's still bad, but when we were having that difficulty and clinics needed to not have parents come in, or there was COVID exposure because of whatever, a classroom exposure, and a child couldn't come in for their follow-up for their ADHD or for even their pneumonia, asthma, throat, ear infections, for those kinds of things. If you needed a follow-up or had follow-up questions, we could just quickly revert to telehealth, do a quick telehealth visit, determine whether or not we could manage it that way, or if the child needed to be physically seen. So it has added such another wonderful level of service. And in fact, I see children on the coast sometimes, and I had recently a follow-up that got reverted to telehealth because the mother was sick, and so she couldn't drive the child in and into my clinic down on the coast. And so what she did was she called, asked for it to be reverted to telehealth. That's what we did. And so we were able to touch base, make sure everything was okay, and then determine when we needed to schedule a face-to-face visit. It is the best thing I think that has happened for us. And it can keep you connected to your medical home. A lot of primary care providers are using telehealth now.
Well, you've given us a whole lot to think about, and I could visit with you for 30 more minutes, but probably we need to wind this up. But with just what you've told us, it's evident that there's a comprehensive approach to, if you want to use the word, educating, schooling children, young children, because it involves health, it involves mental health, it involves cognitive opportunities, exposure to a lot of play, sensory interactions with other children as well as their parents. And so what we want to try to do is to put this out so that folks can understand the complexities of little children and what it takes for little children to succeed. So thank you so much for spending time with us today. And we're going to watch and keep up with how much we thrive as a result of all of the work that you're doing there. So thank you, Dr. Buttross, again for joining us. Thank you.
Thank you so much, Kathy. I want to say one more thing real quickly. And that is, it's not just about kids, it's about our economy. And so if we spend money now, there on these children, there are positive gains early on now, saving special ed, and positive gains later in our workforce. So thank you again. Thank you so much for having me.
Well, that's a great way to end this conversation. So thank you again. Bye-bye.